Hello and welcome to the part 2 of the series, Are Doctors Palm Readers? Well, from the part 1, I'm sure you know now that doctors are not palm readers, but sometimes a doctor may ask you to show me your hands, show me your palms, and then because doctors are trained, they'll be able to make certain diagnoses or differential diagnoses based on what they see or are trained to see. So in the first episode, we looked at the DIP, that's this joint here. And now today we're going to be looking at the PIP. If this term sounds very strange, please have a look at the other video. I'm going to put the link so you could watch that before you watch this. So this is the DIP, this is the PIP, this is the MCP, just the short forms for names that we call this medically or anatomically. So today, for the PIP joint, there are three conditions that could affect the PIP joints. These are osteoarthritis, rheumatoid arthritis, and systemic lupus erythematosus, or SLE for short. So this patient will typically present with pain and swelling, sometimes just pain in terms of osteoarthritis. How then do you make a distinction between these conditions when a patient presents to the doctor? For osteoarthritis, there will be sometimes bony lumps referred to as Bouchard's nodes. Bony lumps referred to as Bouchard's nodes. So in patients presenting with pain in the PIP joints, and you examine or by looking you see those bony swellings, possibly could have osteoarthritis. Number two, rheumatoid arthritis, SLE. I'll put this side by side because there are some features that are similar and some other features that are dissimilar. Rheumatoid arthritis, SLE, usually will occur in a female. So similar, I mean, you can make a distinction between two of them based on the gender because both of them could affect females. Both of them could affect females of, reproductive age. So how then do you make the distinction? Whereas both of them can present with morning stiffness, the morning stiffness in rheumatoid arthritis mostly could last more than an hour. Number two, for patients that have not been diagnosed on time, over a long period of time, patients with rheumatoid arthritis are more likely to have deforming arthritis versus patients that have SLE. Number three, patients that have SLE are more likely to have hair loss, more likely to have oral ulcers. These patients with rheumatoid arthritis may sometimes have some of these features, but typically it will be more likely occur in patients that have SLE, that is lupus. Hair loss, oral ulcers, and usually will be all systemically unwell. So if you find these patients presenting with pain in the PIP joints, systemically unwell, having morning stiffness, usually lasting about 30 minutes, but less than that of the rheumatoid arthritis, you most likely are dealing with lupus. So three conditions: number one, osteoarthritis; number two, rheumatoid arthritis; number three, SLE or lupus. How do you treat these conditions? Number one, osteoarthritis, typically non-steroidal anti-inflammatory drugs, simple analgesics, but sometimes may require the use of intra-articular steroid injections. For rheumatoid arthritis and SLE, apart from the initial non-steroidal anti-inflammatory medications, you typically will use steroids and then move on to conventional disease-modifying anti-rheumatic drugs, and then possibly biologic DMARDs, disease-modifying anti-rheumatic drugs. For rheumatoid arthritis, I'll put description for videos that I've already done, and then down the line, you'll see videos that I would upload for lupus. So hopefully, for this part 2, we've dealt with the proximal interphalangeal joint, also called PIP joint, and you've learned something. If you have, then subscribe. Bye.